Hello friends, today we are going to discuss about the anemia in ICU. Anemia is almost inevitable in patient admitted to the ICU, whereas nearly 50% of patients are anemic at the time of admission to the ICU, usually due to their chronic illness or due to blood loss. The vast majority of the remainder become anemic during their stay in the ICU. There are several reasons why patients in the ICU become anemic, and often patients have anemia due to combination of the causes. So one cause is bleeding. Many patients are admitted to the ICU because of bleeding from the various sites due to trauma, surgery, coagulopathy, and liver disease. Patient admitted for other reason may develop bleeding after admission. The gastrointestinal tract is the most common site of this bleeding, though this may not be obvious in many cases. Coagulopathy, which is very common in ICU patients for a variety of reasons, will certainly contribute to the bleeding. Nearly one-third of the blood transfused in the ICU is for the management of the bleeding patient. Now about the phlebotomy. This is the under-recognized cause of anemia in critically ill. In the average adult ICU patient, approximately 40 to 70 ml of blood is collected each day for investigations, and only a fraction of this collected blood is actually processed. The sicker the patient might have even more blood collected. It must be also remembered that only approximately 12.5 ml of the blood is regenerated every day, and this is not enough to compensate for the blood loss. Increased level of the hepcidin. Hepcidin is produced by the liver and it is the main controller of iron metabolism. The various cytokines that are released during critical illness increase the hepcidin level. This increased level of the hepcidin decreases the absorption of the iron from the GI tract and also traps the iron in its store in the reticuloendothelial system and make less iron available to the bone marrow. This cause of anemia is similar to the anemia of the chronic inflammation. So this is the diagrammatic representation of the anemia of the chronic illness. So the anemia is related to the high hepcidin level and the low erythropoietin level. So next is erythropoietin. Erythropoietin level are significantly reduced in the critically ill patient, and to the compound matters, the bone marrow response to the erythropoietin is also blunted. So RBC production is therefore suppressed. Now the next is decreased RBC life. The lifespan of the RBC is reduced in critically ill patient, probably due to various cytokine release. Now about nutritional deficiency, iron, B12 and the folate deficiency is fairly common in our country, and this deficiency may get aggravated in the ICU because of inadequate nutritional support and the increased demand of this substance in the critical illness. Now the next cause is drug induced. Drugs may cause anemia either by causing immune hemolysis or by the bone marrow suppression. While drug reaction may not be the one of most common cause of anemia, this cause should be considered when there is no other explanation for declining hemoglobin level. Now diagnosing the cause of anemia in the critically ill. While anemia is probably inevitable in most ICU patients, the good history taking, proper clinical examination, and appropriate lab investigation might help to detect some treatable cause of anemia. History and clinical examination. A recent history of recent trauma, surgery, overbleeding from any site must be sought. The patient's drug history, especially history of consumption of NSAID, anticoagulant, antiplatelet agent, bone marrow suppressant, and drugs that may potentially cause hemolytic anemia, like piperacillin, pramoquine, and ceftriaxone. History of any chronic ailment like renal, liver, thyroid, malignancy, rheumatological disease might explain some of the patient's anemia. The patient must be carefully examined for the evidence of overt bleeding, especially puncture site and the surgical wound, icterus suggesting hemolysis or chronic liver disease, purpura ecchymosis suggesting coagulopathy. Now about investigation, we check hemoglobin level to rule out a lab error. Check renal and the liver function. Stool must be examined for the occult blood. A sonography might be necessary in patients who have suffered trauma or have undergone recent surgery, or in coagulopathic patients with no other obvious source of bleeding. High LDH and the reticulocyte count and the positive comb test might suggest hemolysis. Iron binding study will be usually suggestive of anemia of the chronic disease, but might be difficult to interpret in the critically ill because ferritin levels and the iron binding capacity are affected by the critical illness itself. Serum B12 and the folate level may be checked, especially if mean corpuscular volume is on the higher side. In any case, in patient with the microcytic anemia, all efforts to locate the source of occult bleeding, usually the GI tract, must be made. An ultrasound examination might be necessary in patient with the recent trauma, surgery, and unexplained reason for anemia. Peripheral smear must be examined for the clues, suggesting hemolysis and microangiopathic hemolytic anemia. Now, the management of anemia in the ICU. Anemia might have adverse effect in the critically ill patient, especially in those with limited cardiorespiratory reserve and in patient with the neurological problem. There is, however, no strong evidence that treatment of the anemia improves the outcome. Packed cell transfusion are often prescribed for the management of anemia. Transfusion, however, also have side effects like rally, tacho, and immune suppression. The potential risk for transfusion must be weighted against the probable benefit. After the publication of landmark TRIC trial, there has been trend towards restriction transfusion policies in most eyes. Few strategy might help prevent and decrease the incidence of anemia and need for transfusion. Attempts must be made to limit the amount of the blood drawn for the investigation. The use of closed circuit system for blood collection, point of care testing, and the use of small volume phlebotomy tube might limit the amount of blood wasted. Stress ulcer prophylaxis should be initiated when indicated. Early nutritional support with supplement of vitamin and trace element might prevent the nutritional cause of anemia. Then about iron therapy. In ICU patient, iron is not well absorbed from the gut nor is released efficiently from its stool. Oral iron will probably not be used. Theoretically, IV iron might help overcome this functional iron deficiency. Iron supplementation, however, might increase the risk of bacterial infection. The Pyra et al. Conducted multicenter randomized trial of IV iron supplementation for anemia of traumatic critical illness in 2014. The study revealed though that though IV iron increased serum ferritin level significantly, there was no impact on hemoglobin level or the need for transfusion. A recently conducted Ironman study compared IV iron to placebo in the treatment of anemic patient admitted to the ICU. The study conducted that IV iron therapy did not significantly decrease the need of RBC transfusion. However, patients who received IV iron had much more hemoglobin level at discharge from the ICU. All other outcomes were similar in both groups. On the basis of this study, the routine supplementation of IV iron cannot be recommended as yet for anemic ICU patients. Now, erythropoiesis stimulating agent. Critically ill patients are resistant to the effect of erythropoietin. Studies of high dose of erythropoietin stimulating agent in the management of anemia have been disappointing. The increase in the hemoglobin level were marginal, and there was no improvement in any other outcome, and there was small increase in the incidence of thrombotic event. For now, erythropoiesis stimulating agent can only be recommended for patient in ICU suffering from CKD and for patients suffering from trauma. Now, these are the evidences. This is the TRIC trial which was published in NEJM, which compared restrictive or liberal red cell transfusion for cardiac surgery. In patients undergoing cardiac surgery who were at moderate to high risk for death, a restrictive strategy regarding red cell transfusion was non-inferior to the liberal strategy with respect to composite outcome of death from any cause myocardial infarction, stroke, new onset renal failure with dialysis and with less blood transfusion. Then the next TRIS trial was published, which was conducted in septic shock patient who compared low versus high hemoglobin threshold for transfusion in septic shock. So among patients with septic shock, mortality at 90 days and the rest of rates of ischemic events and the use of life support were similar among those assigned to blood transfusion at higher hemoglobin threshold and those assigned to blood transfusion at low threshold. So low threshold group receive the fever transfusion. Thank you guys.